Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Maternal. And L recognize the deviation from the normal and refer such cases for specialized investigation. 1.1 Introduction. Antenatal care is systematic medical supervision including examination and advice to a pregnant woman with the aim to ensure that every wanted pregnancy culminates in the delivery of a healthy baby without impairing the health of the mother. Ideally, this care should begin soon after conception and continue throughout the pregnancy. 1.2 Antenatal care. Antenatal care, UNC, began as a social service in Paris in 1788 for women who were both pregnant and destitute. They were housed in Hôtel Dieu and Hospital Salpêtrière till they delivered. However, you must appreciate that in 1901, Ballantyne expressed concern for malformed babies and stillbirths. He was of the opinion that such mishaps could be prevented by instituting good antenatal care. He was a great visionary and his point has been proved beyond doubt with the development of fetal medicine. Thus began the medical and scientific interest in antenatal care, leading subsequently to organized antenatal care in Europe and USA by the first decade of this century. In India, antenatal clinics were instituted in the 1940s. The Ministry of Health and Family Welfare has recommended minimal antenatal care, i.e. 3 visits, of which 2 should be in the last trimester, third being within last 4 weeks before term. It is hoped that such care will reduce considerably both maternal and perinatal mortality. In 1986, the Department of Health and Human Services, USA, convened an expert panel to review the contents of antenatal care. The panel concluded that medical conditions e.g. diabetes, personal behavior, e.g. alcohol abuse, etc., are associated with bad pregnancy outcome and hence, preconceptional care would be an integral part of antenatal care. In our country, preconceptional is not yet an integral part of antenatal care. Need for antenatal care. It is extremely important to be aware that in India over 95% of maternal deaths occur among women who have never had UNC. In spite of all efforts, 12% in the rural areas receive UNC. The maternal mortality in our country ranges from 100,000 in Kerala to 1,200 to 1,500. 100,000 in the northern states with an average of 100,000. About 30% of the babies are of low birth weight and perinatal mortality is in the range of 70-81,000. Unfortunately, the leading causes of this grim outcome continue to be infections, hemorrhage, anemia and preeclampsia, which, as you will appreciate, can be prevented if we institute intelligent antenatal care. Objectives of antenatal care. You are aware that obstetrics is a branch of medicine that deals with parturition, its antecedents and sequelae. Many of our women come to the hospital only when they are in labor. Good intranatal care no doubt prevents maternal and neonatal mortality and morbidity to some extent, but care during pregnancy, UNC, can help us to detect, anticipate complications which, if taken care, can further improve both maternal and fetal outcome. Therefore, the objectives of antenatal care are to 1. Confirm pregnancy and expected date of delivery, ed. 2. Monitor maternal health. 3. Monitor fetal health. 4. Identify high-risk pregnancies. 5. Detect associated medical, surgical and gynecological disorders. 6. Recognize the deviation from the normal and refer such cases for specialized investigations. 7. Screen for infections. 8. Select cases for domiciliary, hospital delivery. 9. Immunize the pregnant mother against tetanus and other diseases. 10. Educate the mother regarding nutrition and drugs. 11. Educate the mother regarding child care and counsel her about contraception. 12. Screen for cancer of breast and genital tract. 1.3 Initial comprehensive evaluation. At the onset, we should be clear that pregnancy is a normal physiological state. But then, why is that we are so worried and look at UNC so pessimistically? That is because the complexity of the anatomical and physiological changes that accompany pregnancy make some people think of normal pregnancy as a disease. For example, excess of fluid retention manifests as edema around the ankles which disappears after rest is normal, but in case edema is generalized, it is abnormal. It is essential for you to be familiar with physiological changes as well as the pathological changes that may develop during pregnancy. This knowledge will help you to impart better antenatal care and also prompt you to be watchful enough to detect any deviation from the normal. As a physician responsible for antenatal care, it is best for you to adopt a scientific approach, which involves collecting information by way of history, physical examination, laboratory investigations, and interpreting the data correctly in addition to diagnosis of existing chronic medical and surgical problems. 1.3.1 Diagnosis of pregnancy. As you go through this section, you will find that an attempt has been made to delineate essentials of good antenatal care. Remember that bad antenatal care may be worse than none. At the first visit, the pregnant mother is evaluated with the following objectives. 1. To define the health status of the mother. 2. To determine the gestational age and health of the fetus. 3. To initiate a plan for further obstetrical care. Pregnancy is a physiological state, but we must appreciate the need to make a correct diagnosis, and this cannot be overemphasized as it has emotional and social implications. For any doctor concerned with medical, surgical management of women in the reproductive age, the knowledge of existence of pregnancy is crucial to the proper diagnosis and treatment of all diseases. To give you an example, a woman of reproductive age suffering from pulmonary tuberculosis will need an X-ray and anti-tubercular drugs as mode of treatment. In such a case, if she happens to be pregnant, the fetus could be exposed to the teratogenic effects of the drugs and radiation. Abdomen may be shielded to reduce exposure to radiation. Right from the history, we should suspect pregnancy. The presumptive symptoms of pregnancy are cessation of menstruation in all women in the reproductive age with history of amenorrhea. Pregnancy should be suspected. Nausea with or without vomiting. Disturbance in maturation. Fatigue. Perception of fetal movements. The presumptive signs are anatomical changes in the breasts, skin, discoloration of vaginal mucosa. Probable evidence lies in the enlargement of abdomen, softening of the cervix and uterus, uterine enlargement at 6 to 8 weeks. Compressibility of the cervix known as Palmer's sign, internal and external ballottement, ability to discern fetal parts and fetal heart sounds. Confirmation of pregnancy in the early period lies in the detection of human chorionic gonadotropin, HCG, in urine and detection of fetus and placenta on ultrasonographic examination. Presence of HCG is detected by using kits which contain A. Suspension of latex particles coated with HCG. B. Solution of HCG antibody. Most tests become positive at the time of missed menses and they are sensitive enough to detect 50 MIU of HCG per milliliter. However, it will be better to wait for 10 days after the date of missed menses to get better accuracy. However, once the presumptive and probable features suggest pregnancy, it is mandatory that we should confirm pregnancy and hence look out for positive signs. These signs are detection of fetal heart sound by auscultation at 20 weeks of gestation, perception of fetal movements by the examiner, recognition of embryo and fetus at any time in pregnancy using sonographic techniques. Gestational sac is seen by 5 to 6 weeks with an abdominal transducer. Embryonic echoes can be demonstrated by 7 weeks and heart action by 8 weeks. If a vaginal transducer is used, the above signs can be detected a week earlier. 1.3.2 History. You must appreciate that as in any other branch of medicine, the essentials of history taking are the same. A good rapport should be established with the pregnant woman and information should be gathered and care should be taken to record the data accurately. We should realize that a pregnant woman can suffer from the same diseases that a non-pregnant woman suffers, i.e. rheumatic heart disease, diabetes mellitus etc. These diseases can influence both the maternal and fetal outcome adversely. An obstetrical mishap in the past signals a warning for the current pregnancy. Presence of hypertension, diabetes mellitus. Occurrence of multiple pregnancy or congenital fetal malformations in the family certainly has implications. The menstrual history is of very great importance. In a woman who menstruates regularly, Every 28 days, the expected date of delivery, ED, is calculated accurately by Nagel's method, i.e. by adding 7 days to 9 months from the first day of the last menstrual period. LMP. The facts underlying this calculation are that firstly, a woman with a 28 days cycle is most likely to ovulate at mid-cycle, and secondly, the normal period of gestation is 280 days. In the absence of regular, predictable, cyclic, spontaneous menses, dating of pregnancy becomes difficult. Such situations are likely when a woman has been on steroidal contraception, she conceives during lactational amenorrhea, or her menstrual cycles are irregular. In the current pregnancy, some important facts should be noted, i.e. history of eruptive fevers, ovulation induction, exposure to drugs, radiation, vaginal bleeding in the first trimester. In the second and third trimesters, features of PIH, preeclampsia and vaginal bleeding are to be inquired. You will be immensely benefited if the pregnant woman has already had UNC. You must look into the records. You must also take care to inquire about her nutrition, addiction to drugs, alcohol and tobacco. A note should be made regarding previous surgery and blood transfusion and any major illnesses. 1.3.3 Physical examination. General physical examination including height and weight, examination of the abdomen. Cardiovascular, respiratory and nervous systems are absolutely essential in order to assess the health status of the pregnant mother. Particular attention should be paid to the recording of weight and blood pressure. Obstetrical examination is performed with a view to confirm pregnancy and assess the period of pregnancy. After inspecting the external genitalia, the cervix is visualized employing a speculum. You must be aware that cervical cancer is the commonest cancer among women and occurs at a fairly young age in India. Wherever possible, a sample for cytological study is collected from the lower half of the endocervix and the ectocervix using an air spatula. Smears are made on slides and immediately fixed in ether alcohol. The character of vaginal secretions is noted. A greenish-yellow frothy discharge is suggestive of infection with Trichomonas vaginalis. A curdy white discharge is consistent with monilial infection. A wet smear on microscopic examination confirms the diagnosis. A bluish discoloration of the cervix is characteristic, but not diagnostic of pregnancy. If the cervix is dilated, membranes can be seen. On bimanual examination, cervix will be found to be soft, uterus will be soft and enlarged. In very early pregnancy, compressibility at the level of isthmus is suggestive of pregnancy and has been noted in the literature as Hager's sign. At this period, the dating of pregnancy is accurate. Later on, fetal parts may be felt. It is essential for you to remember that the uterus becomes palpable per abdomen, just above symphysis pubis, by the 14th week of pregnancy. Between 20th and 30th weeks of gestation, there is a good correlation between the gestational age of the fetus and the distance in centimeters measured from the symphysis pubis to the fundus of the uterus. 1.3.4 Assessment of gestational age. Having collected the required data, you proceed to assess the period of gestation as accurately as possible. This will be extremely useful when we have to make a decision regarding the timing of delivery. We have already discussed that the period of gestation in the human beings is 40 weeks. Term pregnancy is from the completion of 37 weeks to completion of 42 weeks. Preterm pregnancy is from 28 completed weeks till completion of 37 weeks. Post-term pregnancy is from completion of 42 weeks and beyond. We have to evince special concern in case of both preterm and post-term infants. According to Arias, 1993, the reliability of the expected date of delivery as calculated from the period of gestation can be assessed both by clinical data and findings of ultrasonography examination. Depending upon the accuracy of ED, it could be categorized as excellent, good or poor. Excellent dates. A. Women with adequate clinical information having known LMP, 28 to 30 days cycle, no recent use of oral contraceptives pills, uterine size in agreement with the dates and the ultrasound examination between 16 to 24 weeks indicating that the fetal measurements are in agreement with the gestational age. B. Patients with inadequate or incomplete clinical information but with 2 ultrasound examination between 16 to 24 weeks showing linear fetal growth and similar ed. Good dates. A. Patients with adequate clinical information, as defined above, and 1 confirmatory ultrasound examination after 24 weeks of gestation. B. Patients with inadequate or incomplete clinical information and 2 or more ultrasound examination showing adequate growth and similar ed. Poor dates. Any clinical information different from those listed above. 1.3.5 Instructions. After history and physical examination, estimation of hemoglobin, urine analysis, blood grouping and RH typing should be performed for all the pregnant women. Iron folic acid. Prophylaxis is advocated as 90% of pregnant women in India are anemic. Iron deficiency. Anemia per se and along with other causes is responsible for 30 to 40% of maternal deaths. The pregnant woman should be instructed to attend antenatal clinic in every 4 weeks till 28 weeks, in every 2 weeks between 28 to 36 weeks and then in every week till delivery. As discussed already, Ministry of Health and Family Welfare of India has recommended a minimum of 3 antenatal visits of which 2 should be in the last trimester. First visit should be before 20 weeks, second visit between 28 to 32 weeks for early detection of pregnancy complications, and the third visit between the 36th and 40th weeks to detect the abnormal lie and abnormal presentation of fetus. You will see the necessity of 2 visits in the last trimester where you can detect abnormal lies in presentations and cephalopelvic disproportion so as to prevent obstructed labor and its complications. Hence, the third visit should be done between 36 to 40 weeks. In primigravida, we should particularly look for preeclampsia, which if uncontrolled often ends in eclampsia, a convulsive disorder, accounting for a large number of both the maternal and fetal deaths. Therefore, we have to explain to the pregnant woman and her family the need for regular antenatal care. At the same time, she should be instructed to report immediately if she notices any of the following danger signals: vaginal bleeding, swelling of face, fingers and persistent edema around the ankles, severe, continuous headache, dimness, blurring of vision, abdominal pain, persistent vomiting, chills or fever, oliguria, escape of fluid from the vagina, excessive, markedly diminished fetal movements. 1.4 Health education. Every pregnant woman should be advised regarding nutrition, rest, drugs, alcohol, smoking, exercise, recreation, sexual activity and about childcraft. Nutrition. By now, you have seen the extent of anatomical and physiological changes in the pregnant woman. This demands a special consideration for her diet. Throughout this century, diets of pregnant women have been discussed endlessly. However, a consensus was reached and Research Council, 1989, has recommended daily allowance for women both before and after pregnancy. You will study nutrition in detail in Unit 2 of this block. Suffice to mention that a pregnant woman from the onset of second trimester requires 2,500 kilocalories, 1,200 milligrams of calcium, 100 milligrams of iron and 0.5 milligrams of folic acid and 60 grams of proteins. It is worthwhile noting that excessive supplementation of certain nutrients, i.e. vitamin A and D, can lead to toxicities. Exercise. A pregnant woman can continue her routine work. She may also be permitted to continue keep fit exercises. We should advise her not to undertake heavy exercise in the last few weeks. She needs sleep for 8 hours at night. Women who do physical work must rest for another 2 hours in the afternoon. Coitus should be prohibited only if you have recorded pregnancy complications, i.e. preterm labor, major degree placenta previa etc. Addictions. We should make special efforts to elicit if a pregnant woman is addicted to tobacco, alcohol, and hard drugs. She will benefit immensely if you could take time to counsel her. Ill effects of these substances are well documented, e.g. cigarette smoking has been found to be a common cause of LUGR. Medications. You are aware that a number of drugs cross the placenta and produce undesirable effects on the fetus, such as congenital malformation, and hence you have to warn the pregnant woman not to take any drug without consulting the physician. For all practical purposes, any drug should be avoided in the first 8 weeks of pregnancy, unless the mother's condition warrants their use. More about drugs used in pregnancy will be discussed later. In this unit, immunization. As an obstetrician, you are dealing with two patients, the mother and her fetus. Some of the immunizations, though beneficial to the mother, may be harmful to fetus. The safety of immunization against certain diseases has been questioned. In our country, universalization of immunization against tetanus has almost eradicated its occurrence in the mother and her newborn. 2 intramuscular doses of 0.5 ml each are given 4 to 6 weeks apart during UNC. The last dose is to be given before 36 weeks to be effective. Immunization against measles, mumps, and rubella are contraindicated as these are live virus vaccine. Inactive vaccines like rabies, hepatitis B, cholera, plague should be given when exposed to the risk. Post-exposure prophylaxis with immunoglobulins can be given for hepatitis B, rabies, tetanus and varicella. 1.5 Follow UP of antenatal care. A thorough initial and comprehensive evaluation sets the stage for subsequent antenatal care. Henceforth, you will monitor maternal and fetal health. It is necessary for you to find out from the pregnant woman if she has any new symptoms. If she has, the symptoms must be assessed thoroughly. In the earlier section, we have seen that the pregnant woman should come for checkup every 4 weeks till 28 weeks, then every 2 weeks till 36 weeks, and weekly thereafter. The following should be recorded at every visit. I. Weight gain. 2. Blood pressure. 3. Obstetrical examination. 4. Common complaints. 1. Weight gain. Overall weight gain of a woman during normal pregnancy is 9 to 11 kg. Progressive weight gain indirectly reflects fetal growth. Excessive weight gain indicates fluid retention and it is generally believed to be the earliest sign of preeclampsia. Therefore, it is mandatory that we watch the weight very critically. During the second and third trimester, a pregnant woman should gain 0.3 to 0.5 kg per week. If you recall, primigravidi are more prone to develop preeclampsia. In fact, 80% of cases of preeclampsia occur in primus. Therefore, any weight gain more than 0.5 kg per week is a warning signal and you should monitor such mothers very closely. Presence of edema should be looked for around the ankles and if present you should find out if it disappears after rest. Appearance of edema of face and hands is certainly ominous and needs to be investigated. Lack of adequate weight gain may result in low birth weight, LBW, baby. 2. Blood pressure. Blood pressure should be recorded at every visit. It should be taken with the patient in the recumbent position with a 30-0 tilt towards left side so that the arm is placed at the level of the heart. This procedure should be practiced as a routine because, in the supine position, pressure of the uterus on large pelvic veins and inferior vena cava decreases the venous return to the heart, causing supine hypotension syndrome. A recording of diastolic blood pressure of 90 mm of Hg or more, or an increase of 15 mm of Hg above basal level, and or systolic blood pressure record of 140 mm of Hg or more, or a rise of 30 mm of Hg above basal level are accepted criteria for the diagnosis of pregnancy induced hypertension, PIH, preeclampsia if the rise to blood pressure is observed at least on 2 occasions 6 hours apart. If rise of blood pressure is associated with albuminuria, 300 mg or more per liter in 24 hours, the condition is defined as preeclampsia. Hypertension is also diagnosed if mean arterial pressure, MAP, is increased to 105 mm of Hg. Mean arterial pressure is obtained by adding 1/3 pulse pressure. Pulse pressure is the difference between systolic and diastolic pressure to the diastolic pressure. MAP can also be calculated by the following formula. S2D, where S equals systolic blood pressure, MAP equals 3D equals diastolic blood pressure. 3. Obstetrical examination. You will remember that at the first visit, we assessed the size of the uterus in order to determine the gestational age. On return visits, the size of the uterus in terms of fundal height is assessed. The fundal height you will find was traditionally recorded in relation to the symphysis pubis, the umbilicus and the xiphisternum. As this method is not based on objective criteria, it could not be compared to an established standard of growth. Westin et al. In 1977 introduced gravidogram. The symphysis fundal height, SFH, measured in centimeters is plotted against the period of gestation. A nomogram can be obtained for a given population. Values close to 10th percentile curve suggest intrauterine growth retardation, IUGR, or intrauterine death, and values close to 90th percentile curve are indicative of multiple pregnancy or a big baby. An example of maternal SFH growth chart is shown in Fig. 1.1. You must remember that IUGR accounts for almost 25% of babies in. Therefore, gravidogram can be effectively used as a screening tool for IUGR in a country like ours. The screened cases can be referred to centers for further investigations like ultrasonogram. In the third trimester, especially at the end of third trimester, you would like to examine to determine a. Period of gestation, b. Lie of the fetus, c. Presentation of the fetus, d. Position, a. Fetal heart sound, f. Cephalopelvic disproportion, g. Contracted pelvis. The examination to determine the above points are given in practical manuals. Presence of any risk factors mentioned above and associated obstetrical and medical complications will prompt referral of the patient to specialized centers or admission to the hospital where you are working. Cases that can be safely delivered in PHC's home should fulfill the following criteria: a. Second, third or fourth gravidi. B. Previous good obstetrical history. C. No medical, obstetrical complications. Diagnosis of pregnancy includes good clinical history, thorough clinical examination and investigation so that any associated complication can be detected and correct expected date of delivery, ed., may be calculated. 4. Common complaints. Nausea and vomiting. Nausea and vomiting are the common complaints in the first trimester of pregnancy and occur often in primigravidi. We are not aware of the cause which induces nausea and vomiting, but high levels of chorionic gonadotrophins have been implicated. However, it has been more than established that emotion greatly influence the severity, and you will therefore agree that reassurance, dietary advice to take frequent small carbohydrate meals, may go a long way in the management. Antiemetic medications are rarely indicated. Backache. Backache occurs to some extent in most women. If the backache is severe, a thorough orthopedic examination is warranted. Backache due to muscular spasms usually responds to rest, local heat and analgesics. Varicosities. Another common complaint that you will come across is occurrence of varicose veins in the lower limbs. Besides other factors, increasing femoral venous pressure with advance pregnancy contributes. The pregnant woman may complain of mild to severe discomfort, requiring prolonged rest. The treatment consists of periodic rest with elevation of the legs and elastic stockings. Hemorrhoids. You may recall that varicosities of the rectal veins appear for the first time during pregnancy. But more often pregnancy aggravates previously existing hemorrhoids. Bleeding from hemorrhoids may be responsible for iron deficiency anemia. If bleeding is persistent, hemorrhoidectomy may be required. Heartburn. As pregnancy advances, it causes upward displacement and compression of stomach by the uterus, which along with increased gastrointestinal motility leads to reflux of gastric content into the lower esophagus. In most pregnant women, symptoms of heartburn can be easily relieved by regimen of small frequent meals, avoidance of lying flat on bed, and antacid preparations provide considerable relief. Headache. This is a frequent complaint in the early pregnancy and disappears by mid-pregnancy. In the vast majority, no cause can be demonstrated and treatment is largely symptomatic. However, you must never forget that headache after 20 weeks of pregnancy could be due to pregnancy-induced hypertension, leukorrhea. Excessive vaginal discharge may be normal due to increased vascularity. However, abnormal vaginal discharge should be looked for and investigated. If it is the result of infection caused by Trichomonas vaginalis or Candida, specific treatment should be instituted. The possibility of teratogenicity due to metronidazole has been ruled out. Several large studies Found no increase in frequency of birth defects in over 1,000 women treated with metronidazole during pregnancy. 5. Prognosis. The pregnant woman and her relatives will be anxious to know about how the pregnancy is progressing, the place of delivery, the type of delivery, especially if she has already had mishaps in her previous pregnancies. In spite of pregnancy being a normal physiological state, the complex anatomical and physiological changes render pregnant women prone to certain complications. Hence, the recent evolution of the concept is that every pregnancy is associated with some risk. By considering all the data gathered and the high risk factors, prognosis could be determined. However, you must remember that those selected for home PHC delivery having no risk in the antenatal period could develop certain complications during labor. Hence, arrangements should be made for prompt referral of such cases. 1.6 Drug prescription during pregnancy. You have already read that drugs may be responsible for congenital malformations of the fetus. Therefore, you will appreciate the fact that a lot of precautions are required before administering a drug to a pregnant woman. 1.6.1 Teratogenesis. Period of teratogenesis. A teratogen is any agent or factor to which embryo-fetal exposure produces a permanent alteration in form or function of the offspring. Shepard, 1986. Of prime importance is the time period in pregnancy during which there was fetal exposure. For this purpose, gestation is divided into 3 periods. They are L. Fertilization to implantation, L. Embryonic period, L. Fetal period, 9th week till term. The embryonic period is the most crucial with regard to malformations because it encompasses organogenesis. The classic teratogenic risk period in human beings lasts from approximately 31 days after last menstrual period, LMP, or a few days after missed periods through 10 weeks from LMP. The effect of any teratogen is dependent on timing of exposure and nature of teratogen. Early in the teratogenic period, exposure to a known teratogen may result in congenital heart defects or neural tube defects. Nearer to the end of the classic teratogenic period, malformation of palate or ear may occur. Prior to the time of classic teratogenic period, a teratogen may have all or none effect on conceptus. Thus, an exposure to a known teratogen around the time of conception and implantation may kill the conceptus or may not have any effect at all. You must realize that development of fetus is a dynamic and continuous process, and drugs are known to adversely affect fetus even beyond classical teratogenic period. Such defects may not manifest until the person reaches pubertal age or later. Causes of congenital malformations. Congenital malformations in human fetus could be due to genetic, environmental, or interaction between the two. Historically, till 1940s, these defects were attributed to genetic factors. With the sensational discovery by Gregg, 1941, that exposure to German measles caused abnormalities in the embryo, it became evident that infective agents act as etiologic factors for congenital anomaly of fetus. The role of drugs as etiologic factor for congenital anomalies of the fetus was highlighted with the thalidomide tragedy, 1962. Thalidomide, an antinauseant and sleeping pill, which was extensively used in pregnancy in 1960s, was associated with sudden increase in incidence of limb defects. The etiologic factors for congenital anomalies of the fetus can be classified as follows. L. Chromosomal and genetic factors, 20-25%, L. Fetal infection, 3-5%, L. Maternal disease, 4%, L. Nutritional deficiencies. L. Drugs, 1%. L. Multifactorial, 65-75%. 1.6.2 Guidelines for drug administration for common conditions. Now you are aware of the potential fetal risks involved in drug therapy in pregnancy. Let us now know some of the common drugs that are used in pregnancy with regard to their risk versus benefits. Ideally, a woman who is likely to need drug therapy in pregnancy, e.g. epileptic, diabetic, should be counseled prenatally about the potential risk, the optional usage, dose, and need for careful evaluation of pregnancy well before attempting pregnancy. But as you may be aware, it is common in clinical practice to see pregnant women present to us with history of drug intake, quite often during the crucial period of organogenesis. Nausea and vomiting of pregnancy. This is a common problem in early pregnancy. Most of the patients do respond to rest, reassurance, frequent small carbohydrate meals, and emotional support. In cases of excessive nausea and vomiting of pregnancy, hyperemesis gravidarum, hospitalization, correction of fluid and electrolyte imbalance are the mainstay in the treatment, and antiemetics take a secondary role. There are large number of antiemetics which are used in this condition, which are extensively used worldwide, and there is no evidence that any of the antiemetics are associated with increased risk of congenital malformation after exposure. During the period of organogenesis, especially, merclazine, cyclazine, promethazine, a combination of doxylamine and pyridoxine are not associated with increased risk of congenital malformations when used in first trimester of pregnancy. Farkas and Farkas. 1971, Hymanen and colleagues, 1977. Majority of the drugs in this group fall in category B or C of FDA classification. Analgesics and anti-inflammatory drugs. Almost half the pregnant women use salicylates and acetaminophen during pregnancy. Most investigators have found no association between maternal salicylate injection and fetal anomalies. Hymanen, 1977, Turner, 1975. Aspirin is a potent prostaglandin synthetase inhibitor, and it has been reported to be associated with oligohydramnios, premature closure of ductus arteriosus, and pulmonary hypertension. Levin and Associates, 1978, C. by N. Anand, 1988. Acetaminophen was not found to be associated with increased risk of fetal anomalies in over 500 offsprings from 2 reports. Asselton and colleagues, 1985, Hymanen and Associates, 1977. It has not been associated with duct closure, pulmonary hypertension, or oligohydramnios. However, liver toxicity and fetal demise may result from overdosage. Habak and colleagues, 1984. Nonsteroidal anti-inflammatory drugs like ibuprofen and naproxen are most commonly used in this group of drugs and are considered non-teratogenic. But of concern is the report of possible closure of fetal ductus arteriosus with subsequent pulmonary hypertension and oligohydramnios. Hence, these drugs are generally avoided beyond 34 weeks of pregnancy. Antimicrobials. You must note the fact that almost all the antimicrobials cross the placenta freely. A large number of antimicrobials have been used in pregnancy with apparently no adverse embryofetal effects, but there have been very few studies regarding their efficacy and safety. During pregnancy, antibacterial drugs. Penicillins are probably the safest antimicrobial drug in pregnancy, category B, FDA. Broad spectrum penicillins, e.g. piperacillin, and those with combination of B-lactamase inhibitors are included in this group. Erythromycin is equally safe and only a small fraction of the drug reaches embryo fetus. Cephalosporins are commonly prescribed during pregnancy, and limited data available suggests no embryofetal adverse effects. Category B, FDA. Tetracyclines should be avoided during pregnancy. Category D, FDA, as they cause yellowish discolorization of deciduous teeth and are deposited in fetal bones, although this does not appear to inhibit the growth. Perhaps the only indication to use tetracycline in pregnancy is penicillin allergic patients where desensitization is impractical. Aminoglycosides readily cross the placenta, and streptomycin has been reported to be associated with fetal 8th nerve damage when given to mother over protracted periods. The risk of ototoxicity with use of aminoglycoside in pregnancy appears to be about 1 to 2%. Hence, aminoglycosides are reserved for only serious maternal infections. Chloramphenicol use in pregnancy does not increase the risk of teratogenesis. Heinemann, 1977, but when given to preterm neonate in large doses may result in the classical gray baby syndrome. But it seems unlikely that fetal levels from maternal administration of chloramphenicol would result in gray baby syndrome. Sulfonamides are another group of commonly used antibacterial drugs, and there have been no studies exploring the association of sulfa drugs with congenital malformation of the fetus. The sulfa drugs compete for bilirubin binding sites and may cause hyperbilirubinemia in newborns if given near delivery, especially in preterm babies. Trimethoprim is all antifolate, category C, FDA. and caution is necessary in its use during pregnancy. In studies of infants exposed to trimethoprim sulfonyl-net-haxazole combination during early pregnancy, the congenital anomalies were not increased. Brumfield and Purcell, 1973. Nitrofurantoin is used in uncomplicated urinary tract infection during pregnancy, and in a prospective study of 100 women treated with this drug, congenital anomalies were not increased over control group. Fluoroquinolines are a relatively new group of antibacterial drugs, ciprofloxacin, norfoxacin. And there have been no controlled trials, but according to manufacturer's study, this group of drugs are associated with irreversible arthropathy in dogs. Hence, fluoroquinolones should not be used in pregnancy except in cases of resistant maternal infection. You will surely appreciate the need to know the adverse effects of anti-tubercular drug therapy in pregnancy. All the drugs in this group freely cross placenta. INH is the drug of choice, and it has not shown to be teratogenic in humans. Most of the studies showed no adverse maternal or fetal effects when INH was used during pregnancy. Infants exposed to INH in utero are not at increased risk for childhood cancer. Pyridoxine supplementation during INH therapy is needed to prevent neurotoxicity in both the mother and the fetus. Ethambutol is the next safest anti-tubercular drug during pregnancy, as no teratogenic effect or any other adverse effect has been reported with its use during pregnancy. Rifampicin is known to be teratogenic in mice but not been reported to be associated with any fetal adverse effects in human beings. Hence, rifampicin, when needed, can be used during pregnancy as a third drug following INH and ethambutol. Streptomycin is reserved for only extensive disease because of its ototoxicity and vestibulotoxicity. The other anti-tubercular drugs like ethionamide, cytosine are reported to be teratogenic and should be avoided during pregnancy. No controlled trials are available regarding the safety of pyrazinamide during pregnancy. Antiparasitic drugs. Among antiparasitic drugs, metronidazole is commonly used and found to be carcinogenic in rodents and mutagenic in certain bacteria. Hence, metronidazole use is not recommended during early pregnancy. Hamel, 1989. However, in a study of over 1,000 infants born to women who had metronidazole during first trimester, there was no increase in the congenital anomalies. Rosa et al., 1987. Moreover, drug has not been shown to be teratogenic in animals when given in 5 times the usual human dose. Hamel, 1989. Mebendazole is teratogenic in animals when given in several times the usual human adult dose. However, no reports of teratogenesis has been reported in human beings. There are no adequate studies to recommend the use of broad-spectrum antihelmintics like thiabendazole, pyrantel, palmoate, anticonvulsants. You are already aware that pregnant women with epilepsy who are on antiepileptic medications have a 2 to 3-fold increased risk of malformed fetus, but it is not clear whether it is associated with antiepileptic medications alone or due to some other factors. Phenytoin is most commonly prescribed anticonvulsant. In 1975, Hansen and Smith described fetal Hydantoin syndrome, which is characterized by craniofacial and limb malformations and mental deficiency. In a review of studies that included 460 women taking anticonvulsant, Kelly, 1986, reported that as many as 30% of fetuses exposed to phenytoin had minor craniofacial and digital anomalies. Carbamazepine, another commonly prescribed anticonvulsant, was still recently considered safe during pregnancy. But Jones et al., 1989, reported findings that suggested that carbamazepine may be teratogenic and cause significant facial and digital defects. Valproic acid is associated with increased frequency of spina bifida, and the risk is about 1 to 2% in those who take valproic acid in first trimester. Valproic acid has been reported to be associated with facial and limb defects. Phenobarbital is frequently used during pregnancy, and collaborative perinatal project data suggested that frequency of either major or minor defects in the fetus was not increased with phenobarbital use during pregnancy compared to controls. There are no human studies related to the use of drugs ethosuximide and methoxamide. Anti-diabetic drugs. Insulin is the drug of choice for diabetes complicated pregnancy. Oral hypoglycemic agents, like tolbutamide, are avoided because of possibility of fetal teratogenesis and prolonged neonatal hypoglycemia. Piacidio and co-workers, 1991, analyzed 20 women who had taken oral hypoglycemic agents in first trimester and found that there was increase in the incidence of major congenital malformations of the fetus. Antihypertensives. Hypertension is the common medical complication of pregnancy. Methyldopa is widely used during pregnancy for the treatment of chronic hypertension. Although there are no epidemiological studies of methyldopa used in the first trimester, many years of its use attests to its safety. Hydralazine is commonly utilized in later half of the pregnancy for hypertension without any apparent fetal adverse effects. Adrenergic blocking agents like labetalol, atenolol have been used without any apparent side effects, but very little information is available regarding their use in pregnancy. Calcium channel blocking agents like nifedipine are quite safe in pregnancy. Angiotensin converting enzyme inhibitor agents like captopril are considered strongly teratogenic, causing renal anomalies, and hence their use in pregnancy is contraindicated. Anticoagulants. Heparin is anticoagulant of choice during pregnancy as it does not cross the placenta. Heparin can be given throughout pregnancy and are withheld just before delivery. In contrast, oral anticoagulants like warfarin freely cross the placenta and causes fetal warfarin syndrome, which occurs in about 15 to 25% of the fetuses when exposed during the first trimester. Fetal warfarin syndrome is characterized by nasal hypoplasia and stippled femoral epiphysis. Hence, oral anticoagulants are contraindicated during pregnancy, particularly in first trimester. 1.7 Summary. In this unit you have learned the diagnosis of pregnancy and antenatal care. Aim of antenatal care is to deliver a healthy baby without impairing health of mother and to detect high-risk cases as early as possible so that they can be referred to specialized center. Antenatal monitoring of patient is done regularly. She is called minimum for 3 checkups according to RCH program. At her first visit, pregnancy is diagnosed and complications are excluded by careful history taking, examination and investigations. At subsequent visit, appearance of any new complication is excluded. During these visits she is given advice for diet, rest, prophylactic iron and folic acid and immunization. In our country, tetanus immunization is a routine and essential procedure in antenatal period. Judicious selection of drugs for pregnancy complications has been described. Thank you for watching. We will see you in the next video with the next chapter.